Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled COVID-19's Effect on Access to Care for Underserved Populations, an examination of telehealth and provider attrition. And it was presented on December 16th, 2021 by Clese Erikson and Candace Chen. Hello, my name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. And welcome to our webinar series on COVID-19 and the health workforce. Now, this presentation focuses on COVID-19's effect on access to care for underserved populations, an examination of telehealth and provider attrition. Now, with that said, I'm going to go ahead and introduce our guests today. Today, we're joined by Clese Erikson and Candace Chen, both from the Fitzhugh Mullan Institute for Health Workforce Equity at the George Washington University. Welcome.
So I'm really excited to be with you and Candace and David Armstrong here today to talk with you about the work that we're doing to understand how COVID has affected access to care for underserved populations. We're going to be doing this by presenting 3 different studies. I'm going to start by doing 2 studies of telehealth, one looking at access to care from a consumer perspective and how telehealth affects that. And then a second study that will look at the role of payment parity on access to care and services provided by telehealth at community health centers. And then Candace is going to follow and provide some analysis, some really innovative work she's doing on provider attrition during COVID. I want to start by acknowledging our funder. The National Center for Health Workforce Analysis has provided us the funding through a cooperative agreement to do these 3 studies. And I also want to acknowledge the providers of our data source who have made sort of really unique data sources available to us as part of this that enables us to do this kind of work. The AAMC consumer survey data is, you'll notice we have data from before the pandemic and during. So it's really kind of unique real-time access for all 3 studies that go through 2020 and have prior data so we can do comparisons. This data set will give us access to consumers' perspective on use of telehealth and whether they have that improves their overall access. The Fair Health data is at the community health center level for privately insured populations, and we have pre and during. And then we also have this unique data set for retail prescriptions that give us this perspective throughout the pandemic. So it's kind of an exciting set of data sets to really inform our understanding of what's happening during the pandemic. As a little just sort of perspective, probably all of you are very painfully familiar with what happened during the pandemic, so I won't belabor this too much, but this is some work by Atif Morocha showing the impact of COVID on visit volume in the year 2020. And so there's what I like to affectionately call the before times. All of the visit rates per week are rate set to the first week in March. And you can see it's pretty steady visit volume that, of course, plummeted with the onset of the pandemic and the initial response where we had offices, putting off unnecessary visits, social distancing requirements, really led to a dramatic decline in visits that affected people's ability to provide care and also to get paid if you're thinking about in a fee-for-service environment and you see a significant drop-off in visit capacity. That began to rebound into our sustained response, to the pandemic, which is kind of coming back closer to initial visit rates in that first week. So I think this helps to think about what we're going, that we'll be talking about in terms of both telehealth and attrition, and hopefully we'll reach a time period when there's actually beyond the immediate pandemic, although recent events don't seem to point that direction. When thinking about telehealth policy, when we first came to that precipitous decline, the federal government was pretty quick out of the gate with telehealth policies to increase ability to offer telehealth service with greater HIPAA flexibility, enabling providers to offer telehealth through these applications listed on the right. Federally qualified health centers and rural health clinics could now use telehealth more easily compared to before. Interstate compacts allowed providers to deliver telehealth across state lines. And then there were also, this is just a brief summary. And then another one that I think is interesting is that audio-only telehealth was available to offer medication-assisted treatment. So removing some of the prior visit requirements in place. this is just a subset of the changes. States also quickly responded with policies to improve access, to make it easier to offer telehealth. And there's some real wide swath. This is just a subset of things that change in Alabama and Arkansas to give you a sense. But physical therapy and occupational therapy, speech and language, postpartum visits, optometry visits, new ways of delivering care via telehealth that were newly enabled and covered by Medicaid. Expanded scope for nurse practitioners to offer telehealth, substance use disorder, behavioral health well checks. But important to note, a lot of these are set to expire at the end of the public health emergency, which, you know, with Omicron is really seeming farther and farther away in many cases. Keeping in context, some analysis that we did before the pandemic showed that generally less restrictive state policies were not associated with increased telehealth usage overall or among underserved populations once you control for patient characteristics. And actually, our conclusion was that removing regulatory barriers was not enough. You needed to have an incentive for providers to offer telehealth. And as we all now know, COVID provided that. So we're going to dig into the studies and show you, starting with the first one, which we conducted in collaboration with Natalie Felita and Michael Dill at the AAMC, who provided us with the data, and our research associate, Yoon Hong Park, to look at the relationship between telehealth and access to care, both before and during the pandemic. And our two main research questions were, is use of telehealth associated with greater access to care? So say they can get care when they need it, and at a greater rate than if they said they also use telehealth. And are there disparities in telehealth usage for Medicaid, uninsured, and low-income populations? We ran separate multivariate linear regression models, in both cases looking in the before period and the during period. We used 8 survey waves from the AAMC from June 2017 through 2020. It includes oversamples. This is really important when you want to look at underserved populations. They oversample every other cycle: Medicaid, uninsured, low-income, rural, Black and Hispanic respondents, to make sure that we can get as clear a picture as possible for underserved populations. The data is weighted, and we also, in our models, control for state and survey waves. So, and our key dependent variables were access to care, which was phrased as thinking about when you needed care in the past 12 months, how often were you able to get it? And so we're looking specifically at those who said they were always able to get it. And then for the second set of questions, we're looking at use of telehealth as, in the last 12 months, did you talk with a health provider by video, such as Skype or FaceTime? Yes, 1, no, or don't recall, 0. And when you look over time, we see that this is now plotting for the full time period that we were able to look at. The top line is always able to get care. So for the most part, consumers are able to get care when they need it. It did decline slightly during the pandemic, but it didn't free fall for everyone saying now they couldn't get care when they needed it. And we also document below the percent that reported they used telehealth in the past 12 months. I think it's interesting to note that in 2017, between June 2017 and 2018, self-reported telehealth use was actually declining. I think that's in contrast to what it's not shown here, but when we did some similar analysis on this data set before, we saw it had been increasing steadily up until 2016. So I think some of this has to do with the financial sustainability of offering telehealth. We don't have payment parity. That's sort of a little precursor for thinking about the subsequent study. Then it kind of held steady at about 10% saying they use telehealth, and of course rose dramatically during the pandemic. And so what we want to now understand is, are the people who were using telehealth in the before times, are they more likely to report always having access? And similarly, for during the pandemic, are they, we see that the visit rates didn't fall off dramatically. Is it use of telehealth that is associated with maintaining those visits? And in the first regression model, we plot, this is a simplified model, really just focusing on the role of telehealth and access to care. The orange bars represent before the pandemic, and the teal colored bars are during the pandemic. And we can see, my mouse is just there it goes, that in the before times, telehealth was associated with greater access to care, but during the pandemic, it was not. And this was kind of a little surprising to us when we were looking at this because we thought, well, I mean, all that increased access to telehealth and use of telehealth, but that wasn't what explained it. And so we realized upon thinking about it a little bit more that we sort of conclude that that telehealth was supplementing access to care in the before times by creating new avenues for people to access care. But then during the pandemic, it was associated more with substituting. So instead of going for an in-person visit, now people who had access to care through their insurance or other means were now just switching from going to an in-person visit to a telehealth visit. And I know that I'm one of those people. Even though I've studied telehealth, I never used telehealth until the pandemic. And I think a lot of people are the same way. So it didn't reflect new access for me, just change in location. And then having a usual source of care in both cases is, not unexpectedly associated with that greater access to care. Now I'm going to turn to look at what factors associated with who is using telehealth. And there's a lot to digest here because again, we're showing the before period in the orange bars and the during COVID in the blue bars. And you can see that before, having a usual source of care was not associated with greater use of telehealth, but it was during the pandemic. And so we think that sort of supports the idea of substituting here is that you already had a usual source of care, you're just now switching where you're going to see them using telehealth. Importantly, we did not see in the before times, Medicaid beneficiaries were less likely to use telehealth than those who are privately insured. But during the pandemic, you can see that that disparity in use of telehealth for Medicaid beneficiaries went away, perhaps signaling that the telehealth policies that were enacted across so many different states actually had an impact on making Medicaid beneficiaries have equal access to telehealth. But we did not see, we saw worsening disparities in telehealth access for uninsured populations. And then also for low-income populations, telehealth use was lower for low-income before and during the pandemic, potentially worsening. So that's just a subset. We also didn't see a lot of variation in telehealth use by race ethnicity, except for this other group, which is an unfortunate bucket for in terms of we don't have granular data. It includes people who said they had multiple races or were Pacific Islander or Native American. But that obviously signals a decline in access for that group of people. We need to pay attention to see what's going on there in the future. And then lastly, down here, rural beneficiaries in the before times had worse access, but those disparities went away. So it's going to be incredibly important to figure out how to, when we eventually get to the beyond the pandemic or a more permanent sustained climate for telehealth, we want to think about how can we address the barriers in access that are remaining for low-income populations and others by race ethnicity, and I'll address all these disparities in access, including for uninsured, and do what we can to make sure that the disparities in telehealth use for Medicaid patients don't go away, that we continue to have access for Medicaid beneficiaries beyond times. I'm going to turn now to our second telehealth study, looking at payment parity and seeing whether that is associated with greater use of telehealth at community health centers during the pandemic. And my colleagues on this study are Jordan Herring, Yoon Hung Park, Eric Lowe, and Guinevere Burke. And so this time, it seems a little, we are looking specifically at the privately insured populations at community health centers. That's the data that we had from Fair Health that allowed us to look both before and during the pandemic. And it might seem a little odd because community health centers that privately insured is only 20% of their population, but it still afforded us a great window for examining this concept that if you pay the same for a visit for telehealth as you do for in-person, is that going to lead more providers to actually offer telehealth service at community health centers? which, as we all know, serve low income and other vulnerable underserved populations. And thanks to the Georgetown University's Health Policy Institute, we actually were able to code states for whether they had payment parity for uninsured in place. And the blue states are the 14 states that had payment parity prior to the pandemic. The orange states are the ones that introduced payment parity during the pandemic. And then gray states are ones that you can pay less for a telehealth visit than an in-person visit. So we wanted to find out if that payment parity increased greater use of telehealth at CHCs, and so Fair Health provided us with de-identified patient data. We didn't know any, it was just aggregated at the site level and provided total in-person visits as well as telehealth visits on a monthly basis for medical, mental health, and dental visits. And then we ran logistic regression models to estimate the probability of telehealth usage, controlling for important things like broadband access and rurality of the CHC site, as well as characteristics of the CHC itself in terms of the volume of mental health visits, dental visits, and whether they're a high volume site or not. And this shows a descriptive display of the total visits at the community health centers across all sites throughout March 2019 through, this is actually June, the end point of 2021. And there is a little bit of telehealth that occurs here, but so small you can barely see it. So maybe there you're starting to see a little bit more. Of course, peaking during the initial advent of the pandemic, and then declining, but still substantially higher during the sustained pandemic response over time. This is the second slice of that same data, now dividing CHC sites into the percent that offered telehealth or not during that time period. And you can see telehealth use is low before the pandemic across all CHC sites, and no difference really for the payment parity in state CHC sites in states with payment parity compared to those with no payment parity, including in the initial response. You see that those lines pretty much dovetail, because everyone at that moment was just doing what they could to offer services through telehealth. But in the sustained response, beyond the initial response, you do see a divergence of those lines in states with payment parity offering higher, more likely to offer telehealth compared to those located in states with no payment parity. This holds when we look at the regression models, when we're controlling for other factors, and you can see that that payment parity is in place, that payment parity, even when you control for other factors, is not associated with greater use of telehealth in the before times, which we're looking at each window for March to June 2019, March to June 2020, and March to June 2021. We can see that it is associated with sustained use of telehealth beyond the initial pandemic onset. As is access to broadband is associated with greater use, both in the initial response and in the sustained response. Rural locations have lower access and use of telehealth. And sites with a greater mental health share of visits, even in the before times of 2019, you can see that they actually had greater use of telehealth. And that's because mental health visits were one of the more frequent uses of telehealth across time. And then dental visit share is associated with lower use of telehealth, although teledentistry is actually a thing and an important access point. And then lastly, sites with higher visit volume were the ones that were most likely to offer telehealth across all 3 points in time. So thinking about if we ever get to this after times or even a more sustained, a long-term sustained response to the pandemic, what do we need to ensure that telehealth is available and that it's used to increase access to care? We have learned from both these studies that telehealth is a critical access point during the pandemic, and our first study showed that it was possibly substituting for in-person visits, but not necessarily supplementing access, although it had in the before time. So how do we get back to that supplementing idea again? I think payment parity is going to be an important part of that story. We now have people used to offering telehealth. They've gotten past the barriers of how to set up. And so if we can get more states to offer payment parity, I believe that could be associated with longer term use of telehealth at community health centers beyond ones we've shown now. And then when we looked at the Medicaid use of telehealth in the pandemic from the first study, it showed we did see a drop off in those disparities. So how can we maintain telehealth policies beyond the pandemic that can lead us to be able to supplement access once again? And then this points to the need to continue to invest in broadband access, which is proposed in the Build Back Better and was also supported in the infrastructure bill that passed. And lastly, we want to make sure to pay attention and ensure that we monitor whether telehealth will actually address health disparities in the future, in the long run, or will it introduce new ways of inequities in care. I'm more optimistic that we can use telehealth to increase and address disparities, but I think we do have to pay attention and be sure to monitor whether this is a new way of introducing disparities and inequities. And that's the end of my presentation, and I will turn it over to Candace.
All right, thank you. Thank you, Clese, so much for the great introduction, and David as well for inviting us today. I'm going to be talking about primary care provider attrition through the first year of COVID-19. And the first thing that I should recognize is Clese was very kind to suggest that I led this work, which really it is a team effort, as all good work and good studies are. And Clese, it was actually is actually a very important member of this team, as well as Eric Lowe, Anushi Vishari, and Nicholas Chong. And as Clese mentioned earlier, this work was funded under the HRSA Bureau of Health Workforce Research Center Award. So what is the issue? I think that pretty early on into the pandemic, people started paying a lot of attention to the workforce. And in ways that I think many of us who have followed the workforce maybe were unfortunately unsurprised by, but that really elevated the issue of what's going on with the workforce. And COVID-19 then also placed just incredible strain on that health workforce, which we've seen in some very specific ways that we continue to see right now, I think particularly looking at nursing workforce in hospitals, but really across the health workforce. And those strains included issues of safety concerns early on with access to PPE and just safety in going to work, facing a very, an unknown infectious disease. Illness themselves. In November of just last month, if you look up on the CDC, there's over 750,000 cases of COVID in healthcare workers, and they're estimating over 2,600 deaths in healthcare workers, although even the CDC points out that this is likely an underestimate of the number of deaths in healthcare workers due to COVID. And then the issue of financial pressures, as we were seeing, as Clese was showing, and I'll show you a little bit here as well, as we were seeing visits decrease and the delivery of care really having to change and adjust to, we won't call it a new normal, but this major national global event that we were facing. And so we really started thinking about, well, how do we start looking at this issue of the health workforce and how COVID is affecting the healthcare workforce? And we particularly, we focused in on the primary care workforce, which even before COVID had been facing significant maldistribution, shortage issues in certain communities, all while evidence is coming out showing that stronger primary care workforce is associated with better health outcomes and population health outcomes. And just really quickly, this is actually, I think probably from the same analysis that Clese showed you a little bit earlier, a slightly different view. It's Commonwealth Fund. It's using FREJA data of looking at about 50,000 providers, and this is 2020, and the dark blue line would be kind of previous year trends of outpatient visits, and the orange is what happened during 2020 during COVID. And this is kind of that March, April, May period where you see a sharp decline in the number of outpatient visits, which was supplemented by telehealth visits, and then a return, although in their data, it shows that the outpatient visits didn't actually return to previous year kind of baseline trends. So definitely an effect on outpatient visits. And related to that, this is another analysis by Fair Health data looking at both utilization, and the utilization is this blue bar, and then revenue, which is the green bar, the money bar. And you can see in this January, February time period of 2020, just as we're starting to hear the rumblings of COVID, but before, I think that we in the US had really started dealing with it, that, we're not seeing any particular decrease in utilization or revenue, but in this March and April period, not only do you see that decrease in utilization, but you really start seeing the decreases in revenue associated with that decrease in utilization. And then there's some surveys as well, some really great innovative work done by the Larry Green Center to put up a survey of primary care providers that they did through social media and through various networks. But as early as May of 2020, their week 11 survey had 10% of primary care clinicians reporting that practice members were leaving due to, quote, the harmful new normal. And another survey of Massachusetts provider organizations, so not actually the providers, in May to July of 2020, also found that the practices were reporting that they were either furloughing or laying off providers up to 6% of primary care physicians and 19% of primary care nurse practitioners and physician assistants. But as all of us know, surveys oftentimes are a little bit more limited in their sample size. And we started asking, how can we start looking at this issue of primary care attrition more nationally? And we were lucky enough, actually a lot because of the work that Clese is leading, looking at and building a mental health workforce database. We were lucky enough to have access to an IQVIA data set of primary care providers who are prescribing behavioral health medications. And we had data from 2017 to 2020. And if you don't know IQVIA is a proprietary data set, and the data set is of retail pharmacy claims. And again, we were focused on a pretty wide swath of behavioral health medications. And what we considered active primary care providers is basically anybody who had any new prescriptions for behavioral health medication for the preceding 3 months. And we did 3 months because people come in and out a little bit of prescribing behavioral health medications. So it kind of helped us settle that monthly up and down variation. And then for primary care, we looked specifically at family medicine, general internal medicine, general pediatrics, OBGYN physicians, nurse practitioners, and physician assistants. And what we did is we just did we started with just some descriptive trends from 2017 through the end of 2020 through December of 2020, looking at how many active prescribers of behavioral health medications. And then we looked at the most active providers in the last half of 2018, and then also in the last half of 2019. And we looked at what they did in the following year. So we took providers who were active and indicated as active all the way from June to December of 2018 and looked at whether they stayed active through 2019, whether they, and we have a couple categories of what we call attrition. So people who had no attrition, they stayed active through 2019. People who had temporary attrition, so right in that post-COVID March, April, May period became inactive, looked like they were no longer prescribing new behavioral health medications. We have a category that was, long-term attrition. So they became inactive in that right post period and then stayed inactive through the rest of the year, and then late attrition. So they stayed active in that early period and then became inactive. And I actually have that written out, so you don't have to remember that. And then we compared them to the active 2019 cohort and what their attrition looked like through 2020, through the COVID period, to see, did attrition look different in the COVID period compared to in the cohort from the previous year. So this is just the descriptive, and what you got to begin with is we separated out physicians and nurse practitioners because you can kind of see the pattern of the number of active prescribers is a little bit different. For physicians, you kind of see a little bit of annual up and down, a little bit of annual variation in how active physicians are, and particularly in prescribing behavioral health medications. What these little markers indicate is December of every year. So it would be December of 2017, December of 2018, December of 2019, and then this is December of 2020. And you can see that in December of 2020, there are about 4,000 fewer active primary care physicians if you just look at the previous year, December's. So already just by looking at a descriptive look at the active primary care providers, it looks like something happened in 2020. For nurse practitioners and physician assistants, what we see is just a persistent increase in the number of nurse practitioners and physician assistants who are actively prescribing behavioral health medications. We think that might be two things, although this is our hypothesis, that one, nurse practitioners and physician assistants were actually becoming more active in prescribing behavioral health medications. Also, we saw kind of an influx in growth in the overall workforce. And here you can also see, and I'm sorry, I forgot to point out, obviously, that in this kind of March, April, May period, you see a real dip in the number of active prescribers in that immediate early period of COVID-19. And just like with the physicians, you see that dip in the nurse practitioners and physician assistants, and then you see a return. But if you kind of look at the trend prior to COVID, it looks like the trend may have been mitigated a little bit following COVID-19. So just looking at the trends, it looks like COVID-19 not only had an immediate effect, but may have had an effect through 2020 on the primary care provider workforce. This is just looking really quickly at all the active providers in 2019, the primary care physicians, and basically what they did through 2020. So the ones, there were 204,000, a little over 204,000 primary care physicians who stayed active through 2020, but there were about 3,700 who became inactive in June, but were active in December. There were almost 3,600 who were inactive in June and stayed inactive in December. And then there were a little over 7,500 who, even though they were active in the June period, they looked like they were inactive in the December period. And this gives you just some of the demographics of those different groups. And you can kind of see here, for example, female providers made up about 45% of the no attrition group. In the late attrition group, they looked a little bit less, actually. But maybe a little bit more overrepresented in the temporary attrition group. And there are some other things, but this is all not controlling for any of the other factors. And one of the things that we will see later is that one of the things that might be going on with, and the reason that you see this trend in women is because women having entered and the kind of the gender balance of the physician workforce kind of coming to more equal in later years means that overall female physicians tend to be a little bit lower. I'm not going to spend too much more time, but this is the physicians. We also looked at the nurse practitioners and the physician assistants, and you can see nurse practitioners, again, about 114,000 that stayed active through 2020, long-term attrition, 3,600, late-term attrition, 6,700, physician assistants, we're looking at about 50,000 with no attrition, 1,700 with long-term attrition, 3,000 who were late attrition, active in June, but then inactive in December. And one of the other things that we did do is we thought it was really important to try to hone down and see and to look at local areas, because we know that workforce is a very local issue. And so we can actually look at that active cohort of the most active cohort in 2019. So those individuals, those primary care providers who were active all the way from June through December of 2019, we can look at their late and long-term and late attrition through 2020, and we can actually identify the counties that lost the greatest percentages of their primary care workforce, or that appear to lose the greatest percentages of their primary care workforce. And the kind of dark red and the bright red is counties that lost over 30% of their primary care work, of that active primary care workforce. Some of the limitations to this is this actually doesn't take into account entry into the workforce. So new entrants into the workforce, and we know year by year people will leave the workforce. People would naturally have retired. And so that takes us to our regression analysis, looking at what did attrition look like in 2020, basically compared to what did attrition look like in 2019. And we basically found some concerning things. Probably not unsurprising, I think as many people were expecting, older physicians during COVID had an increased relative risk. Interestingly enough, in the age 60 to 7 cohort, there was a slight increased relative risk of temporary attrition in the COVID time period, but there was also for age groups older than 60, so 60 to 70 and 70 plus, we saw increased relative risk of long-term and late attrition. In terms of kind of what we know about the primary care workforce and areas of concern in terms of maldistribution, we did find that, we didn't see it in the temporary attrition and we didn't see it in the long-term attrition. We did see that that rural primary care providers, and I'm sorry, this is physicians, we did physicians and nurse practitioners separately. Physicians appeared to be, rural physicians appeared to have higher relative risk of attrition, late attrition during the COVID period. Another really concerning finding is we were able to look at Medicaid volume in the prescription data. We can see how many of the prescriptions are for Medicaid populations or not for Medicaid populations. And we looked at each provider's percent Medicaid volume. And what we found is that as their percent Medicaid volume increased, that their long-term and late attrition also appeared to increase. Their risk of long-term and late attrition also appeared to increase. And then the other, to come back up here to the top, the other demographic factor that we found associated with increased long-term attrition during COVID was being female. So we thought some really concerning findings here about who in the workforce was disproportionately being impacted by COVID, as well as then concerns for populations being disproportionately impacted by the loss of primary care providers during COVID. And obviously we think rural and populations, with, Medicaid populations were already at some of the highest risk for issues of access to primary care. Just some quick limitations. Obviously, our data set was limited to behavioral health medications, so it was a very selective view of the primary care workforce. One of the things that we did do is IQVIA was good enough to provide us a list of basically all the providers, all the primary care providers who were in any way active, had prescribed any medication in 2019. So we were able to look at how many prescribed behavioral health medications in 2019 compared to how many were in the overall IQVIA database in 2019. And we found that we were picking up about 67% of family medicine and about 50% of internal medicine, pediatrics, OBGYNs, a little bit less for the nurse practitioners and physician assistants. You should take those numbers with a grain of salt because they're not really a good representation of truly being active. The denominator is if you had any prescription whatsoever in the IQVIA database. There were some data limitations in regards to the provider characteristics. We didn't actually have the age of the nurse practitioners and physician assistants. That's one of the reasons that we separated the regression analysis. We didn't have provider race and ethnicity. Again, as I mentioned earlier, some of our, particularly our regression analysis, and then our that map that I showed you didn't take into account people entering the primary care workforce. So, new graduates and becoming independent providers in the workforce. And then the other thing we were unable to determine was the cause of attrition. So whether it was due to illness or to death, whether it was due to practice closures due to financial strains, or whether it was due to retirement that was either planned or was taken earlier than expected. But some really important implications. I think our findings bring up a real concern that primary care attrition will disproportionately affect communities that were already vulnerable, are rural, are high Medicaid, and that this could make disparities even worse and even worse for decades to come. That attrition may be disproportionately affecting women healthcare workers. And that's something that we should think about if we're if anybody is concerned about gender equity inside of the workforce. And then another issue is that we looked, initially when we ran this, and I think we got our data in March, April of 2021, our study in our heads was named Primary Care Provider Attrition Through COVID. And we had data through December 2020. And you'll now notice that we are saying primary care provider attrition through the first year of COVID. So, following 2020 through this past year, providers might be returning to practice, but I think that we're also seeing that there's just increasing concerns for burnout and the additional effects that COVID is having on the workforce. And so we think that it's really important to continue to track this issue of health workforce attrition, and not just in the primary care workforce. And then the ability to hone down to the county level, down to service areas, we think will be really important, and potentially can be used then to direct policies and to direct programs aimed at, first identifying the communities that are at highest risk, and then working to mitigate those risks. And that is all I have. I think I'm handing it back over to David.
Okay, thank you, Candace, and thank you, Clese. Those were wonderful presentations. Just a reminder to those of you in your audience, you may ask questions using the Q&A panel on your screens. So with that said, I'll get us started with a couple of questions that we already have prepared. Clese, this first question is for you. What are some of the telehealth innovations you think might be most helpful for increasing access and quality of care?
Well, one of the things that I've been particularly interested in is this idea of, in that slide I showed you where the state policies were changing, there was this physical therapy, occupational therapy, and speech therapy. So a lot of that can be done through Zoom, kind of like we're interacting right now. And if you're thinking about, pain management, it's kind of hard to take off time to go travel to a physical therapist or an occupational therapist and get care. But if you can do that from Zoom, potentially even from work location, it becomes easier to actually access those services for patients, and then could be able to prevent people from becoming reliant on pain medications and potentially leading to opioid addiction over time. So I think there's a lot that can be studied there. Well, another important thing that's come along in telehealth is audio only. In the past, that wasn't frequently covered, and now a lot of the policies moved specifically to cover audio only, which again can be a way to break down access barriers for people who may not have broadband access but have access to a cell phone to be able to get ongoing care.
Okay, thank you, Clese. And a quick follow-up. I mean, it was very interesting that you were able to show that, states where there's parity in payment, well, they're still using telehealth at a greater usage rate. But at the same time, as dramatically as telehealth increased at the beginning of the pandemic, it is steadily declining, granted at different rates. Granted, what's your opinion? I guess that's all there can be right now. Is this going to plateau at some point, do you think?
Potentially. I mean, it looks like it's hovered, based on the data that we showed from Atif Moreau. Well, I don't know if I had that slide, I may have taken that out, but his study, and as well as the one of the community health centers, showed kind of plateauing in what I'm referring to as a sustained pandemic response. And, but it's still significantly higher than it has been before the pandemic. Because I think people got over that hump. If you were a provider that wanted to offer telehealth before the pandemic, you had to figure out how to get compliant technology. You had to take time off from your practice. You might not have been paid the same for that telehealth visit or paid at all if the patient's insurance didn't cover it. And you didn't necessarily know whether Medicaid would cover it for this particular thing or that thing, or private insurance would pay or pay the same amount. So with all of that ambiguity, people, I think, were just thinking to themselves, well, it'd be nice to be able to offer that, but I'm not going to invest right now. And another work that's been published shows that less than 2% of providers offered telehealth for primary care, and then behavioral health had slightly higher, 4 to 5% that offered telehealth. Yeah, there are exceptions, like Kaiser Permanente was pretty famous before the pandemic for having half of their visits being offered by telehealth, but that was a really unique circumstance. And that was a lot to do with cultural expectation that they offer telehealth, as well as providing resources like phones to providers to be able to do that, and data plans, and including telehealth as something that you would count towards your new patient visit counts and things.
Interesting. I have to think for those providers that made new investments in this technology, they're going to want to continue to use them, obviously. And once more, a reminder to your audience: if you have questions, by all means, ask them via the Q&A panel. With that said, Candace, I have a question or two for you as well. Your methods were, they're a little out of the ordinary. So I guess I guess I have a question regarding the challenges you had identifying active healthcare providers. Can you talk a little bit about the challenges you had with the data you used?
Yeah, I think that if you look at us and you go, you identified primary care providers by their prescribing of behavioral health medications. How odd, right? And your reaction would probably be a good reaction, a right reaction. And what I think that it highlights, and what we experienced through a lot of our work over the course of 2020, specifically trying to get at workforce issues, is how much work needs to be put into improving the databases that allow us to identify who's active, where they are, in as close to real time as possible. We did some other work looking, and actually Clese has an active tracker looking at state down to county level hospital workforce, because obviously, as I talked about a little bit, and that continues to be an issue right now, this is a big deal. And in the early days when we watched in New York as they were trying to identify, well, who are active workforce, who is a possible workforce, the people who are potentially retired sitting in New York that we might be able to bring back into practice, right? Who are the people outside of New York that we might be able to bring to New York, right? And it became clear that they're just, the fact that we were sitting in the middle of the pandemic, unable to put good data to good decision making, to move critical resources, people around in the most efficient ways and in the ways that would, meet local needs, was just, it was shocking. And so, for example, things like the NPPS, the NPI database, right? And the fact that the NPI database really doesn't require you to update the database. And so one of the challenges of being in that database is that you don't really know where those people are. And you might be able to then bring it to other databases to try to be more active. And again, we ended up with IQVIA, which again is a proprietary database. And I love that we were able to get it, but it's expensive. And so that's another issue of, how do people access the data that's going to help them make the decisions that they need to do now. But on a positive note, I think what the work that we did does show is that you can be creative. You can find ways to do this. We should continue to push both to make the data sets better, to make them more available, and then to use them for better decision making. So it's unusual. We agree. And it really does highlight some of the work that we need to put towards addressing that issue, to addressing those issues.
Yeah, and you only have the data available that's available. And like in New York, we are about to pass the health professions mandatory data collection bill. I'm very happy to say it's on the governor's desk right now. So we're,
Yeah. And hopefully people from other states are listening, because oftentimes it's about, something. And I will tell you, and this is also from Clese's work, the state of Tennessee, if you're ever interested in looking at a very available licensing data, I don't think we've seen a state that makes their licensing data available in quite the same way. Race ethnicity is available for their physician providers, right? Actually, so it is, it's collecting it, and then it's making it available for people to use, not only researchers, but people who are trying to make real life, real-time decisions.
Yeah, that actually addresses a question I was just doing with yesterday. So thank you. Thank you for pointing that out.
David, can I point on one other thing to add to, like, I think Candace is right to, like, it is kind of an odd database, but it also has some strengths and approaches. And one benefit of the prescription data is that you aren't dealing with this whole incident to billing issue for nurse practitioners and physician assistants. So it actually is probably one of the more robust ways of examining their engagement in the workforce. So I think that's another thing I want to highlight. And I just cannot overemphasize anyone who's listening that has any kind of access, power, or authority to collect NPI numbers or ensure people update their records. This is such a powerful way to track people over time. And as Candace pointed out on our, we don't, if we can get better data, not only of whether they're active or not, ensure that their specialty is appropriately reflected. If their practice location is appropriately reflected, we can do so much more to document health workers.
And now since, NPI data is now used, as a starting point for HIPS analysis, federal shortage designations. And a big problem with that, of course, is the address. So if it could get like better information in it, that would be a boon. With that said, another technical question for your piece, Candace. I like maps. I like the map you showed. And of course, a number of counties had no data. And so, you had a little bar through them. But I also noticed like some of the 0% attritions. Was that because of, and it wasn't really clear to me, was that because it wasn't so much no data as there's 0 people there? There seemed to be a lot of very rural areas.
Yeah. And actually, anytime you do a ratio or a percent, obviously the denominator matters as well as the numerator. So some of those higher, if you have, if you're in a very rural area and you have 2 providers and one of them retires, all of a sudden you've got 50% attrition, right? But that means you got 50% attrition in your rural county. So yes, I totally agree with you. Always, we always want to know what we're looking at, but one of the things I always think about rural is it's just because the numbers are small doesn't mean the impact is small.
Yeah, that's true. That's very true. In fact, if anything, I think they tend to stay on a little bit longer as a result, obviously. Another really interesting thing I saw, and I know you speculated a little bit, was about NPs and PAs, how they're prescribed and has gone up over time dramatically. I really wonder if there's something to look at there as an additional study almost.
We should ask Clese, because Clese, like I said, is doing a lot of work and looking at the mental health workforce. Clese, what do you think?
Oh yeah, that is definitely a priority area for us because we've seen such dramatic growth in NPs and PAs. We can document it in our data set. And I think that's just a powerful, and one of the things we're showing is that they are more likely to go into rural communities and underserved, and others have done that before. But then, we can link over time, and with our database that we have, we can actually look at provision of medication-assisted treatment over time. We are looking at characteristics of counties in terms of whether providers are even there at all. When you raised the topic of there are a lot where we didn't have data, there are a lot of counties where there are no providers available. And so we're doing some modeling to really understand how measures of social vulnerability impact whether there's a provider there at all. And we're finding racial and ethnic disparities that are poignant of whether you even have one. And then second, we're looking to see how measures of vulnerability impact the overall supply of providers to the population in communities that are underserved. And with the IQVIA data, which is the source we're using for that, we're able to look exclusively at providers who treat Medicaid and uninsured populations. So it's a lot that we can do with this data set.
Yeah, one other question, Clese, on your study. Telehealth has really taken off, since the pandemic. It's really, there's a lot of innovation going on right there. Are there any other studies out there that support the idea of telehealth as a way to supplement access to care?
Well, one that I like to highlight, they don't specifically talk about supplementing, but it was one that came out of California by Lori Usher Pines, and it was looking at community health centers there and showing that similar to what we found, telehealth maintained access to care, and it was through audio only. And I just can't help thinking, if we move beyond the pandemic, but keep audio only, that points to and continue to reimburse that as well as other telehealth services that previously haven't been covered. that holds a lot of potential to once again supplement access to care with telehealth. And a lot of researchers for medication-assisted treatment, others really support this idea of audio only because there are a lot of advantages of being able to connect people in real time. You don't have to wait to schedule an appointment. Perhaps for some of those, you can do almost like a warm handoff. And I think there's a lot of opportunity to really understand the impact of that on access to care.
Thank you. Once more, these were wonderful presentations. We are approaching the top of the hour. So with that in mind, do you have any closing thoughts? Like if there's one thing a person should take away from your study or studies, what is it?
Advocate for sustained changes to improve payment parity and other the Medicaid expansions. I think that is going, if those go away, I think we're going to see a dramatic decline in telehealth usage, which could have important access applications for Medicaid, uninsured, and others.
Okay, thank you, Clese.
And I think from the primary care attrition, I think it really is that there's a lot of concern that COVID is going to have a number of negative impacts on the workforce. Primary care attrition is just one example, and it's important that we give this the attention that it deserves, and we make sure that it doesn't then translate into just worsening disparities for the communities that have already been facing significant disparities in access, quality, outcomes coming into COVID.
Okay, thank you. And really, once more, thank both of you for wonderful presentations. I found the conversation very enjoyable. And also, thank you in the audience for attending our event today. We certainly hope to see you again in the future. But with that said, I hope everyone has a good afternoon and, of course, enjoy the holidays. Take care, everyone. Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.